Thank you very much, Debbie and Tom, much appreciated. Well, we could all do with a new drug. We're looking at opioid-free alternatives for multimodal analgesia. Not so much new drugs, but better ways of combining them. I have no disclosures. Instead of thinking of multimodality pain management, we can think of multi-targeted pain management, and it's a central tenet of ERAS protocols, which are based on fluid management, maintenance of function, as we were just hearing, pain control, and above all, audit, so that we know what our results are. If you have a patient whose pain is well controlled, they don't act like a patient. They're up and out of bed, they're eating, they're not having the side effects of opiates with nausea and ileus. So I think it's helpful to think of pain management in 4 phases, not just post-op, which is how we've been doing that for a very long time, and use medications that work at various parts along the pain pathways or the pain chain, while at the same time minimizing or even completely avoiding opioids. And I'm going to make a blatant promotion here. I have nothing invested in it, but the SAGE's Opioid Task Force recently, with the stalwart help of Erin Swartz in the office, had the opioid.org website go active with multiple resources to help with safe pain management and particularly with avoiding opiates. So if you look at the pain pathways, there are multiple places where pain medications can work, starting with the brain stem, the spinal cord, the nerve roots, and the peripheral nerves, and the actual site of injury. And we can put this together in terms of thinking, when can we give those medications? And the 4 phases of pain management start even before the patient even comes into the hospital. So how can we tie the pain pathway together with the phases? Well, it's helpful to think about it in terms of what medications can be given orally and which need to be IV, because those are the ones that will be used intra-op by our anesthesia team, and early post-op if the patient, for whatever reason, is unable to eat. So there's a lot of information here. So what's the best way of approaching this? Pick and choose a med from the various groups with different targets. So for example, pre-admission, one of the components there isn't a medication at all. It's pre-op education that allays patient anxiety. It's been helpful in some studies to start pre-op preemptive meds 48 hours beforehand, so they have 5 T-half times to obtain steady state with those meds. Typically, that has incorporated a COX-2 medication, acetaminophen, and gabapentin. Our institution, however, similar to many others, has taken gabapentin off a lot of pre-op orders because of a post-op increase in falls, particularly in the elderly. In the immediate pre-op period, we hold acetaminophen so that we can give it IV at the end of the case. As mentioned, we've been avoiding gabapentin, but we do give celecoxib and go over the pre-op education. Intra-op, there are anesthesia considerations and surgical considerations. And what we've done is add an anesthesia pause, which follows immediately after the surgical pause. Typically, on induction, fentanyl is used to blunt the tachycardia that comes with intubation. Short-acting opioids probably have very little effect on post-op ileus. But esmolol and other beta blockers can also be used for that induction. Typically, I do a block in the abdominal wall at the beginning of the case, and therefore ask the anesthesiologist not to use any more narcotics for the duration of the case, and this usually works quite well. Right at the beginning of the case, before incision, we use NMDA inhibitors. So for example, anesthesia will start an infusion of magnesium after a bolus, and the same with ketamine. Either boluses or an infusion can be used. Then we give IV acetaminophen at the end of the case so that the patient has that on board going to PACU. And we save ketorolac for the PACU nurse to give rather than opioids. Without those precautions, enhanced recovery protocols tend to die off in the PACU. But by doing this and having the patient's pain well controlled before they even get to PACU, We've cut back immensely on the amount of opioids that are used there. Again, try adding an anesthesia pause so that everyone's on the same page. You are a team. Obviously, for the surgeon, use minimally invasive techniques when feasible because this minimizes pain. Learn some kind of abdominal wall block. Either have your anesthesia team do it for some of the more complex ones, like a quadratus lumborum block, but there are other ones that surgeons can readily adopt. Ultrasound tap, rectus block for incisions above T10 or the umbilicus, subcostal blocks, transversalis fascia block. The two-tap random lap tap is not accurate, and it's better to learn an anatomically based block. So typically lap tap you see constrained by the drapes, ultrasound tap in the mid-axillary line, lateral quadratus lumborum, and a laparoscopic transversalis fascia block. By doing these different blocks and learning them over a period of time, we reduced narcotics, here shown in morphine milligram equivalents over a post-op 2 or 3 day period, from over 40 MMEs to 10. Research the available options for your injectate when doing a block. There are short and long-acting medications. The long-acting one that many of us are used to, if permitted in your institution, is liposomal bupivacaine, originally approved for hemorrhoidectomy, bunionectomy, but now used on tissue planes and local infiltration. A new medication, a combination of bupivacaine and meloxicam, is now also available, having been approved earlier this year by the FDA, currently for bunionectomy, open inguinal hernia, and total knee arthroplasty, but like with the other medications, will probably broaden its scope. The injectate can also be mixed with adjuvants such as saline to facilitate spread in a tissue plane, steroids or epinephrine to improve duration. We currently use a mixture to optimize the spread in the plane. Post-op, acetaminophen and ketorolac or ibuprofen are scheduled. Low-dose ketamine infusion, particularly for folks on chronic opioids pre-op. Non-pharmacologic measures should not be underestimated, such as heating pads, ice packs, binders, etc. Breakthrough pain, low-dose narcotics, such as low-dose oxycodone, tramadol, which is a relatively mild synthetic narcotic, and then short-acting narcotics, if necessary, for significant breakthrough pain. And remember, a patient doesn't have pain, they don't act like a patient. Thank you.